Okay, so obviously a lot of work went into development of new guidelines, and the next step is to get doctors and patients to actually implement the guidelines. So I was asked to address achieving buy-in of the new guidelines by professional organizations, and to be honest, the first thing that came to mind is luck, but that wouldn't make much of a talk. So the 5 factors that I think are most important for achieving buy-in are listed here, and I'll go through them one by one, starting with the guidelines have to be based on evidence to the extent that evidence is available. And for, I'll be speaking mostly towards the ACS, ASCCP, ASCP guideline. This is an overview of what the literature review looked like for our guideline. It was extremely extensive, systematic. We identified over 11,000 publications dating back to 1995, and we had a process for reviewing these. And if you look at the last bullet, we also were fortunate to get access to the evidence review from the U.S. Preventive Services Task Force, which we coordinated the timing of our guideline review with theirs, and were able to look at perhaps any papers that they identified that we didn't, or that they chose not to include to consider for our own. We also used the GRADE framework, and not only is being evidence-based dependent on how much evidence is available, but there's a lot of wiggle room in here. And so you start with just identifying what the questions are that you want to look at. And if you word the questions a certain way, you may come up with a different answer than if you word them another way. Also, you have to identify outcomes, and these have been discussed by previous speakers. We looked at, for example, identifying early detection of SYN3+ as the main benefit of screening. But another group might look at finding cancer only or decreasing cancer mortality. And you're going to get different recommendations depending on what your benefits or harms are, or what you choose for those. And then if you look down at the 4th bullet, you have to judge the balance of benefits and harms. And again, there's a lot of wiggle room in here. So here's one example, and Shalini talked about this. And there was, I think Marc also talked about how you can have 2 different perspectives, or more than 2, on what constitutes the right judgment. If you have a slight, and slight is subjective, increase in benefits by screening more frequently, but you have a large increase in harms, could 2 different people look at this and come to different conclusions about which one to recommend? So the next factor is to include a lot of different experts that represent different perspectives and different backgrounds. And for our guideline review, we had a lot of different committees. We had a lot of interaction between committees. We had a lot of expertise on different work groups. We had a lot of organizations and individuals invited to a meeting that voted on different recommendations and saw all of the evidence. And all of these people represented a lot of different subspecialties. The 6 working groups are listed here, and you heard from many of them. And so we had experts in different sub-areas of the key questions that we looked at. Include different organizations as well as different experts. And we were fortunate that we had 3 groups who were interested in coming together and working together to sponsor the guideline. We also had 25 organizations participate, some of them by having representatives on one of the different committees that I just showed you, others that came to the meeting and participated in the voting process. And this, again, helps to get buy-in, because you need the organizations present during the process, and you need individuals who saw how it worked. You need to build your credibility with these individuals so that they can go back to those organizations and get the support that you need. But when you do this, there are a lot of organizations that are clinician-based. They're subspecialties with an interest in cervical cancer screening and prevention. Many of the experts that you'll want to use will have financial ties. You just can't avoid that today. But even beyond that, and this was mentioned before as well, clinicians, even if they don't have the financial ties to industry, are still affected by their own practice. Less screening may mean less patients and less reimbursement for them. And so we looked at all of these and developed a very specific conflict of interest statement. And this, I feel, added to our credibility in getting more buy-in. And what we did is we said pretty much everybody has a conflict of interest in some way or other. And we tried to balance these. So on each of our committees, on each of our work groups, we had people, if they had a financial conflict of interest, they had to report that. We had that transparent on a website. We also required independence from financial ties for certain categories within this guideline structure. So anyone on the steering committee, anyone who was a co-chair of one of the working groups, and anyone who served on our guideline writing committee could not have any financial ties. And we also did not include anybody from industry who worked for industry in this entire process. And probably the most important factor is to try to get consistency across guidelines. So as was mentioned, there are 3 groups that have developed and released cervical cancer screening guidelines in the US, the American Cancer Society, the US Preventive Services Task Force, and the American College of Obstetricians and Gynecologists. And I've been asked many times, why don't we just have one guideline? And all I can say is it's completely impossible. Everybody has their own process, and as I mentioned, everybody can look at evidence and come up with different conclusions. They can ask different questions. They can say that, you know, this should be the benefit or that should be the benefit. This is one slide that Walter Kinney presented at our guideline meeting, and the quote is from the review done for the U.S. Preventive Services Task Force that concluded that experts agree on, et cetera. And as Walter said, the experts don't agree. So, and I don't think I'm telling you anything you don't know, but so this is extremely challenging to find consistency across groups that have so many interests and so many different ways of interpreting data and their own agenda, their own conflicts, and their own beliefs about what's important for cervical cancer screening. So again, luck did play a big part of it, but also just this whole collaborative effort. And so what we came out with, as you've seen, is virtually identical guidelines among the 3 groups, and the only significant difference between the 2 is that word in red, which is preferred. So 2 of the groups said that co-testing is the preferred approach, whereas the Preventive Services Task Force didn't quite go that far. And I do think there was a lot of luck, but also a lot of hard work in getting the U.S. Preventive Services Task Force, who started with a draft recommendation last fall that said there's insufficient evidence for or against HPV testing or co-testing, and they came around and supported the same recommendation as the other groups. There was a lot of coordination as far as timing, evidence. They sent representatives to attend our meeting. Walter's presentation, I only showed you one slide, had slide after slide of this is what you said, this is how we respond. There were meetings behind the scenes, after the meeting, before the next day, to try to get consistency across guidelines, because in the United States, there are several important professional organizations where their policy is to automatically support the U.S. Preventive Services Task Force guideline, whether it's for cervical or any other screening guideline for cancer or not. And so if they didn't have the same guideline as us, no matter how strongly their groups supported some of our guidelines where we differ, they would have, by their own policy, had to support the U.S. Preventive Services Task Force. So that's why I think that this particular factor was probably the most important. And that's it.
Terrific. Thank you, Debbie.